in like situations that otherwise shouldn't. So you probably are familiar with these patterns. One that probably is a little bit more significant or high yield is actually how you differentiate these from like primary pulmonary causes of frequent infections. And one thing that actually we have seen, like, by seeing these patients throughout the years, is whether or not they have like a single, like, anatomical locations versus multiple sites in the respiratory tract. For example, if they involve the upper airway and the lower airway, in like a different infections, for example, if they are associated with manifestations of pulmonary involvement and extrapulmonary involvement, those are much more likely to be a systemic disorder compared with the ones that usually affect one single anatomical locations that usually are secondary to anatomical lesions or primary pulmonary causes. The atypical organisms, this is something that you probably are familiar as well. There are what we call signature organisms or index infections that always should be a reason for an extended workup. And we see two examples on the screen. For example, the Burkholderia cepacia infections. There are very few conditions, mainly CF and chronic granulomatous disease that cause this. The atypical mycobacteria, as you know, belong to the category in clinical immunology causing susceptibility to this. So those are some of the clues to infectious manifestations in the lungs. However, today we're going to focus in a probably less common or less I would say studied scenario in general, and I will say is clinical manifestations that we are all aware, but probably are much less organized on how to approach them, and that's why I usually like to emphasize this. So I'm gonna present a clinical case. So this is a child, it's a 5-year-old girl that was admitted to the intensive care unit in the institution I was working in with severe rhinovirus pneumonitis. As relevant past medical history, she had had a hypoparathyroidism at 4 years of age. In terms of infection, she didn't have much. She had had ear tubes at the age of 2, which is very common, and had one previous episode of uncomplicated pneumonia. We don't know if that was viral or not at the age of 2, that improved at home. So that was her infections history. But what happened when we saw her? We saw her 3 months after the initial presentation. At that point, these were her labs. So she had increased IgG. She had still very elevated inflammatory markers. She had transaminitis, and she had mild anemia. If you look at the basic phenotype, that immune phenotype that was done at that time, that was normal. So besides these features, she didn't have much else. But it turned out that this patient, over approximately a year during the follow-up, developed this hepatitis was diagnosed as autoimmune. She developed an inflammatory arthritis in her hands. And when we checked her lungs, she actually continued to have interstitial lung disease. So that was a follow-up after an initial image in the intensive care unit, but approximately 3 months later, these lesions persisted. So with all these manifestations all together, we thought, well, this patient likely has an immune dysregulation disorder, and actually her genotype was confirmatory for APZ or AD deficiency. So this is just an example of one immune dysregulatory disorder that initially impacted the lungs, but ended up being a systemic manifestation, a systemic disorder with a lung manifestation. So this is to say that inborn errors of immunity also present with inflammatory lung manifestations, and they are more often than usually than initially thought. These inflammatory manifestations usually can present in two ways, two main clinical pathways how these patients get to us. Number one, when they have a diagnosed inborn errors of immunity, in those cases, is our responsibility in the clinical immunology setting to screen and monitor patients for this. Or sometimes they may come through our pulmonary colleagues or intensive care unit colleagues, sometimes with an acute or severe pulmonary manifestation. In those cases, actually, we talk about this topic with many of the specialties because we want people to have a high index of suspicion in those cases. Just think like that these patients presented with your atypical pulmonary disease, the patients that is with a severe ARDS in the ICU, the patient that sometimes is on ECMO, like because they had a viral infection, sometimes they may have an underlying disorder and they should be screened for that. So how do we approach this? So with 600 molecular diseases, sometimes you think, okay, where do we start? So this is actually a question that we have been thinking for some time, like how do we organize this information, like kind of in a way that we did it, for example, for very early onset inflammatory bowel disease, which now is a clinical syndrome, and that has like a clear pipeline to work out this patient. We want this to become something like that. So we want like basically these kind of manifestations to be in the mind of pulmonologists, intensivists, hospitalists, all people dealing with patients with respiratory manifestations, to have these disorders in the back of their mind and know how to manage and how to start the initial approach to these patients. So how do we do it? So actually, this was a work that we developed a couple of years ago, a few years ago, with some of you. I don't know if Sonia is in the call, but we say, okay, let's try to organize this in a rational way. So we partner with our pulmonary colleagues and we say, okay, let's characterize or catalog manifestations. And the first thing that we did was to divide the lungs in 4 lung compartments, which for pulmonologists is what they do all the time. So we're going to characterize the manifestations of inborn errors of immunity in each of these compartments. So the 4 compartments are the airways, the lung parenchyma, the blood vessels, and the pleura. And actually, if you look at the manifestations that are there, you probably are familiar with all of them, but they just need to be localized anatomically just to make them easier to remember. Like, for example, from the pulmonary standpoint, the airway involvement has certain implications, the parenchymal involvement has other implications, and so on. So we're gonna go over some examples of those. So usually, like for pulmonary diagnosis, images are very important. So especially in children, sometimes it's difficult to make biopsies for a pathological diagnosis. So CT scan, high resolution CT scan images are usually one of the first diagnostic modalities that you use. And in images, you actually have imaging patterns that correlate with the type of anatomical lesions that we just mentioned. So this was actually an algorithm that we designed, actually one of the pulmonologists in our group designed to approach these patients. So when you look at CT scan images, so number one, high resolution CT scan should be part of the diagnostic workup of patients with a suspected lung involvement immune diseases. Sometimes, for example, in pediatric patients, we may be afraid of the radiation. Sometimes we may be afraid, sometimes there may be access problems, but uh, this is very important. So it's, if you suspect one of these disorders, like these images in like a multidisciplinary management in partnership with radiologists and pulmonologists is very important. So what do we do? So there are a few important imaging patterns that can guide the diagnosis. The first one is the involvement of the airways, that is usually detected as stream butt lesions, bronchiectasis, air trapping, sometimes abnormal aeration patterns, such as the mosaic pattern. There is involvement of the intralobular septa, which actually are the connective tissue that divides the pulmonary lobules. So they are like kind of um, septa of connective tissue that carry the blood vessels and the lymphatic vessels of the lung. Why we're mentioning that? Because sometimes when they are inflammatory manifestations, especially when there are cell infiltrations that come from the systemic circulation, those are the first places when those cells accumulate. So that is the reason why sometimes you may see patterns described as reticular or thickening of the interstitial septa or honeycombing in severe like chronic cases. The other pattern is the nodule pattern. Is actually those lesions are in the lung parenchyma. They are not on the airway. They are not in the interstitial. They are classified as interstitial patterns, but actually are usually granulomas or cell infiltrations in the lungs when you look them from the pathology standpoint. And there is another pattern that actually is the occupation of the alveolar space that we see in the form of ground glass opacities. So as you see, these patterns correlate with the anatomical location and sometimes give you clues about the origin of the lesions or the images that you're seeing. Like, for example, whether there is something in the bronchial tree, whether there is like inflammation, edema, or cell infiltration in the interstitium, or if there are nodules that are usually of inflammatory origin, sometimes can be infectious too. So here are some examples of the patterns that we just mentioned. So there is a reticular pattern. In panel A in the slide, there is a reticular and nodular, like when you see the septa thicken plus, little dots, nodules in the lung parenchyma. There is also ground glass opacities in panels D and E there. And there is sometimes when you have a mix of most of them. So using this framework, we actually took the uh, catalog of inborn errors of immunity that we had in year 2022 and looked at what was described in the literature in terms of pulmonary involvement in those conditions and summarize it for this work. And here is what we found. So what we found is that, for example, and this is actually based in the IUIS classification of inborn errors of immunity. So for the major groups, uh, especially the combined immunodeficiencies, as you may know, in terms of respiratory infections, these patients may have pretty much everything, ranging from common infections to rare and opportunistic organisms. And in terms of inflammatory complications, they may have involvement of the airways in the form of bronchiectasis, which is very common, but also interstitial pattern. This actually is a kind of a heat map that we did for the paper, kind of summarizing like the involvement of the compartments that I just mentioned in each of the genetic disorders that we found were described to have pulmonary involvement. So, for example, we are not going to go over each of these manifestations, but just to show you like how to interpret these if you want to look at more information on the paper, like the black areas actually mean that that compartment is involved. Like, for example, if you look at like one common one, like ATM deficiency or like ataxia telangiectasia, you see there is common involvement of the airway and common involvement of the interstitium, which is here. And this, we actually did this summary for multiple combined immunodeficiencies. We found a specific group that actually were much more susceptible to lung disease and was the DNA repair defects. These patients have a lot of bronchiectasis, have early onset interstitial lung disease with rapid progression to fibrosis, and also have, as you know, radiosensitivity and elevated risk of malignancy. So they represent a very special group where pulmonary disease is very common. We also looked at some specific manifestations, and among the syndromic combined immunodeficiencies, we saw patients with hyper IgE syndromes, which actually have very special lesions. Like we found that pneumatoceles are almost exclusive of this group of disorders. We didn't see them in like many more other inborn errors of immunity. So whenever you see a pneumatocele in a patient or like cavitary lesions in a patient, this is actually high injury differential. In terms of antibody deficiencies, as you know, the airway was very commonly involved pretty much in all the diseases and in like most of the diseases that we saw. So actually there are papers now saying that these patients should be screened specifically for airway and pulmonary disease on a regular basis because airway involvement is very common. In addition to the airway, certain patients, as you know, especially those with GLILT, present with granulomatous and interstitial lung disease that requires a special treatment. In terms of immune dysregulation disorders, as you see here, and you probably have seen in your patients, interstitial lung disease is a common manifestation of this group of disorders. And this is another category where we probably should be screening these patients on a regular basis for the presence of interstitial lung disease. For like, just because of a matter of time, we're not gonna show that data here, but we actually found, like with Sonia and some pulmonologists in Bogota, did a recent work investigating the phenotypical characteristics of patients with ILD in common viral immunodeficiency, and actually saw that they have a specific phenotype where, for example, cytopenias are more common, lower class switch B cells are more common, so they represent a separate group. So probably we should be thinking about high risk groups, like who are the patients that, based on their immunophenotype, things that we usually monitor on a regular basis, should go to screening of pulmonary disease. Here are two examples. So you are familiar with these two, are probably some of the most common T-regulopathies. These patients have bronchiectasis with airway involvement, and they also have parenchymal involvement in the form of interstitial lung disease and granulomas and nodules. Why is important to recognize these? Because we have targeted therapies for those that, in addition to controlling the systemic manifestations, usually help with the pulmonary disease. So for example, if you happen to monitor patients like before and after treatment, some of the lesions revert or improve when targeted therapy is started in time. There are other groups, such as the defects of phagocytes that predispose to a number of infections. There is a little bit more variability here, and most of the complications are related to those infections. However, for example, patients with chronic granulomatous disease also have interstitial involvement. Some others in this group, such as GATA2, may also have that. So in general, they are the ones that present with immune dysregulation phenotypes. Those are the ones that usually tend to have interstitial lung disease. In this group, there is a specific pulmonary manifestations. It's pulmonary alveolar proteinosis that in general patients with defects on the macrophages that we think may affect the alveolar macrophages are more predisposed to this. So this is a kind of a index manifestations that when you have it, you probably should be working those patients for these kind of conditions. Here is a picture of a patient with chronic granulomatous disease. As you know, these patients are very susceptible to infections by catalase positive organisms, empyema abscesses, but also granulomas in some cases. And probably one group of disorders that we are not, you know, in contact on a day-to-day basis because they usually go to the rheumatology office is the autoinflammatory disorders, but they are also a cause of frequent lung involvement, and we'll see some examples. Importantly, they don't have that many infections, but they affect the interstitium and the vascular compartment much more commonly than other categories. For example, in SAVI, this is a disease that causes small vessel vasculitis, as you see in this child. Sometimes may present with acrocyanosis triggered by cold, especially, because of the vasculitis. These patients are characterized by early onset interstitial lung disease. So whenever you see a case of like an isolated ILD in a child, besides the primary pulmonary causes, you probably should be working them up for this. There is another disease in this family, the COPA syndrome. These patients present with interstitial lung disease, but in addition to that, have alveolar hemorrhage, sometimes massive pulmonary hemorrhage, usually of early onset. We are often called to consult on those patients with a suspicion for like an ANCA-associated vasculitis or something like that. Usually ANCA-associated vasculitis are not, at least in their classical form, are not typical of young children. However, you may see ANCA in this disease. So whenever you have that combination of ANAs positives with ANCA positive antibodies and alveolar hemorrhage in a young child is probably not a GPA. Is something that should be screened for this condition. And there is another example, much less common, interferonopathies, in addition to the pulmonary hemorrhage and interstitial involvement, can cause pulmonary alveolar proteinosis, especially this disorder. This usually doesn't happen in isolation. These patients have severe pulmonary involvement, usually with opportunistic infections, and they usually have more immune dysregulation manifestations that usually present in combination with the lung involvement. So in summary, what we may say is that the lungs are very frequently affected in inborn errors of immunity, and they present with infections and non-infectious lung disease. To make it easier to approach these patients, we should be thinking in terms of the 4 anatomical compartments and in terms of clinical and imaging patterns of disease that correlate with this anatomical location and with the molecular diagnosis. So what do we do for this patient? You probably are familiar, like they usually have like a combination of diagnostic approaches for inborn errors of immunity. Everything starts with a good history and exam. The clinical suspicion is key because you have to think about this in order to request the specific test. And we use usually a combination of genetic testing and functional testing. Whenever you are thinking about lung involvement, this actually resembles the approach to early onset IBD. Molecular diagnosis is key, use it early. So we usually, like depending on the setting that you're working in, you may have available whole exome, whole genome sequencing. Sometimes you have only like targeted panels. In general, we prefer the whole exome or whole genome sequencing approaches, but if you have a panel, it's also fine. Just make sure that you order it in combination with the pulmonary panel that screens for primary ciliary dyskinesia that today has over 40 molecular diseases. And how do we treat these patients? So it's usually a multidisciplinary treatment, and it depends on the underlying cause and the underlying manifestation. So it usually involves a combination of appropriate pulmonary clearance, inhaled therapies, use or not of antibiotic prophylaxis. Whenever we have a molecular diagnosis, it's very important to treat the underlying disease, ideally with targeted therapies in cases such as the CTLA4, LRBA cases that I showed you. We have a disease-specific immunomodulation, which also helps the lung manifestation. Sometimes we have to add on specific therapies for the lung manifestations, such as in the cases of CVID with GLILT. Sometimes you have to immunomodulate only for the lung manifestations. So this is usually disease specific. It's not the focus of this talk, but this is an area that we have a lot of work to do, especially because we probably haven't found like a unified approach. I think the first step is to start actively diagnosing these patients and actually finding ways exactly what happens at the level of the local immunity in the lungs in order to develop better treatments. We have some, and here are some examples. If you have like a more detailed look at this is actually a table modified with the publication that I just mentioned to you. And this may be a little bit outdated because this paper actually has 3 years already. But these were like some of the therapies that were in use by then. And actually, I just wanted to kind of take the last part of this presentation to mention another aspect of this topic. So far, we have talked mostly about rare conditions, but we always have to keep in mind that inborn errors of immunity may also present as common disorders. And actually, we have very good examples since the pandemic, where we actually see patients with severe respiratory disease, most of them without genetic cause, but some of them with one. So the question that we ask every time that we see a patient like this, either like in the intensive care unit or with a severe respiratory infection, is can they have an inborn errors of immunity? And we're gonna go briefly over that. So this is something that we knew before the pandemic. So we knew that there were some genes, especially in the interferon pathways, that predisposed to severe viral infections, viral respiratory infections. But we knew a few. We also knew that there were autoantibodies that especially detected at the systemic level that could predispose to this. However, it was with COVID, one of the few good things that we learned from the pandemic. It was that actually it actually helped us to understand viral immunity better. So after the COVID pandemic, there was actually an increased number of diseases that were identified. As you see here, they are mostly in the interferon signaling pathways. For example, the ones in red were the ones that were discovered after COVID-19, include for example, MyD88 and IRAK4, we knew that they were immunodeficient, but we didn't know this aspect of causing susceptibility to viral infections. We suspected that we could have a STAT1 or STAT deficiencies causing viral infections, but we just didn't know patients with that. After the pandemic, we found patients who presented with COVID, with severe COVID infections, or sometimes with other respiratory infections. Importantly, we became much more aware of autoimmunity in the form of immune dysregulation and autoantibody production, causing phenocopies of these deficiencies, especially because of production of type 1 interferons. Those were identified as causes of severe COVID pneumonia and severe influenza infections. And probably one of the most interesting things about this was that they were initially identified in the systemic circulation, but then this study actually detected that local autoantibodies in the alveolar space were also present in patients with severe COVID-19 pneumonia, which actually highlighted the importance of the local immunity, which I think is an interesting finding. There were other studies similar to this. For example, this one included pediatric patients. Initially, we thought that the autoantibody production was secondary to senescence or increasing age. Here, this study showed that children can also have that, and it included children starting from 6 years of age. So, in summary, what we learned from this is that common respiratory infections have also taught us a lot about antiviral immunity. And from practical purposes, this should be a category of patients that we probably should be screening for inborn errors of immunity in certain cases. I usually get a frequent question about whether you should screen everybody. And this is my personal take. I don't think we should screen anybody because most of these causes are non-monogenic, but the question is who you should be screening for these conditions. I think this is a work in progress. And importantly, we have monogenic defects, but also autoimmune acquired like secondary causes of like with production of anti-cytokine antibodies that produce phenocopies of monogenic immunodeficiency. So whenever our genetic testing is negative, we should be thinking if this may be a cause as well. And just for the last few minutes of the talk, I just want you to focus on this problem, and is the infants who we often see in the intensive care unit with severe viral respiratory infection. So the question is, what is the problem, and what determines that some infants are maybe asymptomatic, happy at home, whereas some others go to the hospital or probably to intensive care unit with a respiratory infection. That actually has been the goal and the focus of our recent research. And I'm going to show you a few data of how we have been approaching this problem. So what you see here is actually focus on mucosal immunity. Local respiratory immunity is actually a big determinant of susceptibility to infection in these patients. What we see here is the analysis of a single cell RNA sequencing data set that actually showed that it's 36 donors ranging from newborns to adults. And what we see here is that if you focus on the blue spot, those are the airway B cells. And what we found in this work was that actually before 1 year of age, infants had no B cells in the mucosal surface. And suddenly those cells colonize or populate the mucosa between ages 1 to 6 years, which is an expansion. And then they gradually decrease until just a few cells by the adolescence years. So we were very interested in this finding, and we looked a little bit more about those B cells, and what we found was very interesting. So you see here that young children have more B cells in general. These are subsets of B cells. So we see naive B cells here. We see memory B cells, like mature memory B cells here. And we see these cells that look like memory but are more transitional, and these ones that people call cycling. What is important about those cells and I want you to concentrate in this plot here, is that they express this gene. This gene is the one that encodes the adenosine deaminase, I'm sorry, AID, the enzyme that actually causes class switching. In addition to that, you see that these patients, these cells here, showed germinal center markers, which suggested to us that these cells were actually germinal center like cells, just circulating through the nasal mucosa in early childhood that looked as they were undergoing active programming because of active expression of this gene. If you see here, these genes were, these cells were much more abundant in the early childhood ages compared with the older groups. And the other marker that we looked is, okay, how are those cells living there? So what we actually looked is, what happened with their survival receptors, which actually are very specific in order to see how they are like actually not dying in the nasal mucosa, which is usually not a survival niche for these cells. And what we found here is that actually BAF was very important for these cells, and they barely had the other two BAF receptors. So that actually told us that these cells have high expression of BAF receptor, which means that are probably highly dependent on BAF receptor signaling for their survival. So we say, okay, what other cells are important in the nasal mucosa? And we wanted to look at epithelial cells. And what we found was that actually among 10 factors that produced by the epithelium that signal to B cells, only BAF had an age-determined pattern. What we saw is that actually before 1 year of age, airway epithelial cells don't express BAF, and this secretion increases after 1 year. So this is the same timing of the B cells that we saw. So the question after this is whether there is a specific survival niche and a special crosstalk between airway epithelial cells and B cells in the nasal mucosa, actually helping shape mucosal immunity, specifically B cell immunity in early life. So actually, this is an standing question. We don't have the answer yet. What we have found after that is that actually viral infections have to do with this axis too, because they activate BAF production and they activate interference. This is actually a mechanism that is dependent on JAK-STAT. So this is another aspect of the JAK-STAT pathway, just acting as regulators of BAF expression and by extension of B cell function in the airway mucosa. And this is basically where we are. So the summary of this is that actually the local mucosal immunity is very important for localized immunity. The key to understanding susceptibility to infection, especially in certain conditions such as young ages, may be there. And but this is a work in progress. We still have a lot to learn about determinants of susceptibility to respiratory viruses. So in conclusion, what we know from this topic is that the respiratory system is central, is key to inborn errors of immunity, because sometimes can be the first or sometimes the index manifestation of one of these disorders. We should be thinking about inborn errors of immunity in children who present with one of these manifestations, especially the inflammatory, that sometimes are not too obvious part of inborn errors of immunity. And we should be screening our inborn errors of immunity patients for these disorders, because sometimes this involvement may be silent. Whenever you suspect these conditions, molecular diagnosis is critical, should be done early. However, not all diagnoses are monogenic. We have learned, especially after COVID, about secondary acquired immunodeficiencies such as autoantibodies and immunodeficiency phenocopies. There are also developmental factors that cause immunodeficiencies, immunodeficiency, if you want to call it, and we are starting to understand it. And in general, lung diseases and immune disorders is a very hot area for clinical practice and for research. And saying that, I will end this presentation and I'm open to questions. These are the two papers that I mentioned to you. In case you want to look at additional data, and I'm happy to answer questions like now. And if you want to contact me, please feel free to do it. This is my contact information.
Thank you, Dr. Gutierrez, for your excellent lecture on pulmonary involvement in inborn of immunity. As part of the Juniors Committee, we would like to thank you because it was a fantastic talk, and you focused very well on how important it is to work all together, pneumologists and immunologists. So with that, thanks to you, I would like to open the questions. We already have two questions of Dr. Oscar Porras from Costa Rica. He asked you, first of all, that in Costa Rica, ataxia telangiectasia is the most frequent inborn of immunity. Do you consider a preventive protocol for chronic lung disease in very young AT children?
That's actually a very good question. In general, AT is a very severe disease. We know actually they are an exception to the rule of doing images relatively frequently because they are radiosensitive. So you usually have to be very careful with them. Use a low radiation protocol for those patients and always be aware of the radiosensitivity and the predisposition to malignancy on those patients whenever you do this. There is actually a really good paper. Is a little bit old. It's from 2010, but it's still valid because it was written by two people who actually have a lot of experience of ataxia telangiectasia. Is Dr. Sharon McGrath, who I mentioned to you, and Dr. Howard Letterman, who's actually a colleague of mine at Hopkins. They have one of the largest world series of ATM patients, ATM deficiency patients. So that is a good source. Saying that, we don't have like a consistent or clear, way to, we have pieces, but not like a dedicated protocol to be screening these patients.
Okay, I think that you answered very well, Oscar, question. And the second one is in patient with XLA, BTK, how preventive of chronic lung disease is it the early use of IVIG?
Those patients need immunoglobulin replacement, all of them, because they have like a complete antibody deficiency. If you probably have seen those patients, they probably will not survive if they don't have like immunoglobulin replacement. So yes, in addition to the replacement, these patients have to be on a continuous monitoring schedule that includes images and aggressive treatment of infections in order to prevent the complications. One of the main problems for them is the airway, like the formation of bronchiectasis is a major problem for them.
Okay, thank you. I didn't see other questions. They are saying congratulations to you. That was a brilliant talk, as we said before. I don't know if someone else wants to ask something or we should finish in order of time. Well, I think that that's all. Thank you again, Dr. Gutierrez. It was wonderful. Remember that these sessions are then uploaded to the YouTube platform so everyone can see it. So I think that's all.
Okay, perfect. Thank you so much.
Thank you.
So
Thank you
much
for
the
connecting.
invitation. Okay, bye-bye.
Bye.
Bye.
So we have the final announcement. Rafa, do you want to make them or do you want me to say it? I'm fine.
You can finish.
Okay, so remember that we are waiting for you to this last meeting that is being taking part in Buenos Aires here. So we are expecting you to come on October 15 to 18 this year. Next one. I think that's all, maybe. Well, yes. Also remember to submit to the collection. Oscar said before that we are inviting all the juniors to participate on these curious collections. So you're all invited. And the next webinar that we are having in La CID is on September 17. It's taking part of Andrea Risicelli of angioedema hereditario treatment. So you can connect it here. It's going to be really interesting. And finally, remember that you are all invited to the journal Human Immunology, that is the new platform dedicated to the research in human immunology. Here you have the QR to connect. And finally, remember to join LACID, to send your cases. I think that yes, we have already closed the clinical cases, but we are going to see you all there. And thanks God, the registry is back. So send your patients and we can stay all connected with the registry. That it's really important to know how many patients we have in Latin America. So I think that's all.
Okay.
Well, thank you very much, Dr. Gutierrez again, and my juniors committee team.
Okay, thank you so much for the invitation.
Have a nice night.
Good night. Okay, bye-bye.
Bye.